The next segment that we're going to look at deals with some skin conditions, and we're going to look at just a few skin problems. The first one I want to talk about is contact dermatitis. Contact dermatitis we can think of something like poison ivy. You could also think about things like maybe allergic reactions to detergents and other things. But I want to focus primarily on poison ivy type of reaction. So this is an immune reaction to a specific antigen, such as poison ivy. Now, poison ivy, as you know, is a plant that just crawls everywhere in many parts of our country. And many people are very sensitive to the oils in the leaves of the plant. If they get in contact with the oils that are in the leaves of the plant, some people get a very serious reaction to it. So they can get redness and swelling and little vesicles, and these vesicles will ooze and crust over. And it itches incredibly. The treatment for poison ivy is, there are various ways to treat it. One is to give a solution that will dry it up. So something like Burroughs solution. A lot of folks simply use over-the-counter medications. They will use topical drugs like Benadryl ointments that will help to deal with the itching. They might take Benadryl by mouth to deal with the itching. They might take topical steroid ointments, topical antibiotic ointments if they have a secondary infection. Sometimes we try products like calamine or Ivy Dry, things that are going to dry it up and deal with the itching. We also need to teach people to stay away from the irritants, stay away from poison ivy. Just a couple more thoughts about poison ivy. If a person has been walking through the grass or the woods and where the poison ivy is, and poison ivy is on their clothing, unless they wash their clothing with a strong soapy water, the oils from the leaves can still be on the plant. So if they were then to touch their blue jeans or their clothing and rub, put their arm or hand on it, they could get another poison ivy infection. So it's important to wash the clothing to get rid of those oils. Poison ivy can also be contracted sometimes from pets. So if the family dog has been running through the poison ivy and the oils are on the patient's fur, on the dog's fur. If the oils are on the dog's fur and the child goes and hugs and loves up on the dog, they could also get a poison ivy infection. Poison ivy can be in burning leaves as well. If people are burning leaves in the fall and poison ivy is in those leaves, the people that are very, very sensitive to poison ivy, just the oils that are in the smoke and the ashes would be enough to give them a serious attack of poison ivy. Now, another skin problem that I want us to take a look at is psoriasis. In psoriasis, people get thick, scaly skin. Usually it's in patches, and there's areas of thick, scaly skin. The skin is growing 7 times faster than normal in people with psoriasis. So the treatment for this is going to be try and slow down the rapid skin growth. So patients may be getting topical corticosteroids. So they may also be getting coal tar. That's right, coal tar. And if they have coal tar put onto it, we don't want them to get in the sunlight for a good 24 hours after the coal tar application. Now, another treatment that seems kind of opposite to that is ultraviolet light. Now, clearly we wouldn't do the two at the same time, but ultraviolet light is sometimes used. Antimetabolites such as methotrexate. Now, you think of that, oh, that's a cancer drug. Well, what do the cancer drugs do? They interfere with cell division. So the patients may be given antimetabolites to try and stop that rapid cell division. So that's basically how we're treating psoriasis. Psoriasis is not a life-threatening disease. It is an image-threatening condition, but it's not a life-threatening condition. Now we want to talk a little bit about skin cancer as well. And when we talk about skin cancer, there are really three types of skin cancer. There's basal cell, which is the most common, and fortunately it's the least serious. It almost never metastasizes. Squamous cell carcinoma is a bit deeper. It grows more rapidly and can metastasize. And malignant melanoma is the most serious. This is a killer. Malignant melanoma, fortunately, is the least frequent, although it's becoming more common in America today. Now, basal cell skin cancer is usually treated simply in the doctor's office. If they diagnose a basal cell, it's usually removed in the doctor's office, and that's probably enough. It's not likely to cause an ongoing problem. Squamous cell is also probably going to be removed in the doctor's office. Malignant melanoma, if it's very small and very early, possibly can be removed in an outpatient facility. But it can spread, it can metastasize, and it can kill people. If you don't want to get skin cancer, don't unnecessarily expose yourself to the sunshine. Trying to sunbathe and get beautiful deep tans increases your risk of malignant melanoma and other forms of skin cancer. If they gave you a question on the exam and said, who's at greatest risk for skin cancer? You want to choose the person that is fair-skinned and is outdoors a lot. So who would be more apt to get skin cancer, a football player or a basketball player? And the answer would be, of course, the football player, because that's an outdoor sport and basketball is an indoor sport. Probably the most at risk would be a lifeguard, a blonde, fair-skinned lifeguard, or a farmer who's always outdoors. So reducing that ultraviolet light exposure can reduce the risk of skin cancers. A couple other problems I want us to look at. Herpes. Herpes zoster is shingles. And herpes zoster or shingles is chickenpox the second time around. It's the same organism that causes chickenpox. It's the virus that causes chickenpox. Usually we see shingles or herpes zoster infection in people that are older or people that are immunocompromised. So cancer patients that have been taking cancer chemotherapy or radiation. AIDS patients would also be at high risk for herpes zoster or shingles. And this is very interesting because what happens is that chickenpox virus just hides in your system, and when you're immunocompromised, it may show up again, and it climbs along a nerve root. So it follows a nerve root. So it never crosses midline. So it might start in the middle of the back and follow a nerve root all the way around, but it never goes across the midline in the front. Or it could do the same thing in the face, but it would not cross the midline. That's how you know it's on the nerve root. It's very, very painful. So there's pain on the nerve root. There's usually redness, a rash, often blisters along that nerve root. As soon as the person thinks they might have shingles, they really should go to their healthcare provider, because the sooner treatment is started, the more successful it will be. Usually the patient is going to get one of those cyclovir drugs, like acyclovir, famciclovir, ganciclovir. There's a bunch of them. They're going to get one of those drugs and sometimes a steroid. The sooner it's started, the more likely they are to be cured of that condition. It's very, very painful. Now I want us also to think about herpes simplex, and we have two types of herpes simplex. Herpes simplex 1 is your cold sore or your fever blister. And herpes simplex 1 we treat with those cyclovirs as well. Most people at some point in their life have had a fever blister, but some people get recurring fever blisters, and if they do, what we want to do, what most doctors will do, is give them a prescription for one of these cyclovirs with the instructions that at the first sign of tingling or the sign that that is coming back, then they're to start taking their medication. And that can shorten the outbreak and reduce the frequency. It does not, however, cure it. Now, the same thing is true with herpes simplex 2, which is genital herpes. We can shorten outbreaks and reduce frequency, but we can't cure it and we can't prevent transmission of it with these cyclovir drugs.